Hello, my name is Amy Glover, and today I'm going to be presenting to you the case study and assessment results for my client, a 39-year-old female, and we're going to begin with client history for this client. First of all, the source and the reason for the referral for this client, the client was referred to me based on a pastoral referral regarding concerns with discord within the family unit due to client reporting increasing in depressive symptoms and increase in anger. The client is a 39-year-old female. She is married and a mother of three. She is currently self-employed, but also uses part-time work as a substitute teacher to help supplement her income. The client stated that she does have a bachelor's degree in business and that she also subscribes to a Christian worldview, which influences her view on mental health and what treatments she would be willing to consider. The client states that the problem that she came in with was the increase in anger, obviously, and the increase in depressive symptoms. She stated that this has started to influence her discipline technique with her children. Either she goes from one extreme to the other where she doesn't care and lets them do what they want to, or in her words, that she explodes on them. And she gave a few examples of that, one being her children, she felt one evening were taking too long to go through their nighttime routine. So her response to them was an immediate, what she described as a yelling tirade that included cussing and screaming at her children. And she said at one point she got so angry that she picked up a baseball and threw it and came close to hitting one of her children in the head. She said another instance was that her infant child was crying one afternoon, and she went to go pick the child up, and she said all of a sudden she felt like she couldn't take it anymore, and so she just screamed at the child, put the child back into the playpen area, and walked off from the child for over an hour. Now, the client also informed me that she's only been living where she's at for about 3 years, that her and her family moved about 3 years ago for a job promotion for her husband. The client also expressed that this job promotion keeps her husband away from the family 4 to 5 times a month. So she stated that family time is very important to her, but it is hard for them to all get together with her husband being gone so frequently. She stated that she loves to hang out with her friends. She listed her mother, who lives close by, and her church small group as her support group. The client expressed a concern about almost a worry about not being able to live up to a standard that she sees all of her other friends living up to. As we got more into history, the client stated that she has no suicidal thoughts at this time, and that she cannot recall having any. The client gave mental health history on her family, and said the only mental health issues that was in her family is on her father's side. Her father was diagnosed with major depressive disorder when she was in high school, and then during this time that her father was hospitalized for a brief time. She stated that she had a paternal uncle who, when she was 12 years old, committed suicide, and she reported that this uncle had a long battle with drug addiction. Other than that, she said there's no history of physical violence in the home, and there's no history of sexual assault or sexual abuse in the home. So the client was given, after the interview portion, she was given 2 assessments, the MMPI-2 as well as the MCMI-3. And the client, both of these assessments were given to the client via online, and her results on those were pretty consistent with what she was reporting. And we're going to look at those results right now. I've got some charts that I'm going to pull up here, and let me show you what we have regarding the validity and clinical scales report for the MCMI-2 first. So in those validity and clinical scales for the client for the MMPI-2, you can see that she reported consistently throughout the test. There was no infrequency based on the fake bad scale, the VRIN, or the TRIN. What was interesting to me is that she scored the highest in the area clinical scale of paranoia, which she did not report any paranoia symptoms or indications of that within the interview setting. So it was interesting to me that the assessment in this portion resulted in that. What we'll look at next is the client's result in the content scales portion profile of the MMPI-2. What you're going to see here is that the client scored over an 80 on the anger content scales, and this is consistent with what she was reporting when she came in during the interview. Another thing that was assessed in the MMPI-2 results were the Psyc, scales, and so those include aggressiveness, psychoticism, disconstraint, negative emotionality, or low emotionality or introversion. And so you're going to see in her scores there, they were kind of even across the board. There was nothing that was elevated or above 65 that was clinically significant. So now I'll show you that slide. So the critical items that were endorsed on the MMPI-2 results are the following: acute anxiety state, depressed suicidal ideation, threatened assault, situational stress due to alcoholism, persecutory ideas, family conflict, somatic symptoms, sexual concern, anxiety and tension, deviant thinking, depression and worry, deviant beliefs, substance abuse, and problematic anger. So that is kind of a wide range for this client as far as what she endorsed on her results. So what we're going to look at next are the client's results of the the MC-MI3. So these results were a little bit, to me, more easier to interpret because there were fewer scales that you needed to look at. So that is what we're going to take a gander at now, is the client's MC-MI3 results. So the MC-MI3 assessment is interpreted through base rate scores. Base rate scores that are 65 or higher can be cause for concern. And the base rate scores for this client in 3 separate scales were higher than 65. For the scale 2B depressive scale, the client scored very high in the temperamentally woeful subscale and worthless self-image subscale. In the 8B masochistic or self-defeating scale, the client scored high in the discredited representations or the undeserving self-image scale. And in the scale B, borderline, the client scored high in all 3 subscales: the temperamentally labile, interpersonally paradoxical, and uncertain self-image. And here's the graphic for that. The Grossman facet scales are also measured through the MC-MI3, and I pulled up a graphic here, made a graphic to show you exactly what were of concerns for this client as far as the Grossman facet scales are concerned. So in short, based on the client interview and behavioral observations, the assessment results, and the criteria found in the DSM-5, it is the conclusion of this presenter that the client possibly consider a diagnosis of persistent depressive disorder or dysthymia with late onset, moderate, but close to severe. And based on this information, it is concluded for a recommendation that the client, first of all, receive a full physical evaluation and possibly a psychiatric referral to discuss the use of medications. This could be difficult with this client as her worldview that she subscribes to may impede those discussions on medicinal treatment. Counseling sessions should begin immediately, weekly, and the client should definitely develop a healthy support system. So in the closing of this presentation, I will show you a proposed treatment plan, and hopefully this would be something that the client could take with them into a true professional and present them with this as far as having a base for where to start in working with the clinician to develop her own goals. You can see based on the treatment plan that I did incorporate a lot of cognitive behavioral therapy, including Beck's cognitive behavioral triangle that looks at the connection between thoughts, feelings, and behaviors. It is the belief of this student that CBT and the mind are very important in dealing with depression because you have to address those cognitive distortions and those automatic negative thoughts in order to find a place to begin working towards progress and towards healing. So I hope you guys enjoyed this presentation, and I'm praying for all of you. I hope you all finish strong, and May is almost here. Woohoo!